Ireland, Driving Road Deaths to Zero. Now, we have a number of people who have registered for the event, and I can see you're just starting to come in, so we're delighted to welcome you to the event this morning. I will just remind you that this is actually being recorded, and we'll be making it available on our YouTube channel and circulating it to everybody who has registered for the event. I know we've had over 75 have registered for that. Generally speaking, we usually find not everybody who registers is able to attend on the day, but they're able to pick up on the recording at a later date. So I suppose the first thing I really wanted to say is, why are we doing this at all? Some of you will be already quite familiar with the work of Alcohol Action Ireland, but for others it's maybe the first time you've encountered us. So we're a policy and advocacy group. My name is Sheila Gilheany. I'm the CEO of the organisation, and we're also joined by our Head of Policy and our Head of Communications, Owen Ryan, and our Head of Communications, Conor Keane. So between the three of us, recently we have been working on a new report which looked at specifically the issues around alcohol and road safety. And this for us has been very much a complementary thing to a lot of our other work, where we look at, alcohol in the round, and we look at some of the harms that come from that. We look at ways and means of trying to reduce that harm, whether that's through a reduction in the amount of advertising that we see from it, or whether it's in relation to, for example, pricing policies or other issues there. But we often find that, some of these issues will converge in certain areas. For us, when we looked at the data around alcohol and road safety, I have to say there's so much that is very concerning. We know right now that sadly road deaths are increasing on our road. In the year to date, they are now 10% higher than they were last year. Some of that we know, sadly, will have an alcohol component. When we look at data from previous years, we know that about a third of driver fatalities would have a positive toxicology for alcohol. And given that knowledge, it's one of the things that we think can be addressed, can be looked at it, and hopefully will be something that will actually try to address the issues that are being experienced, and the trauma especially that is being experienced on our roads here in Ireland. So following the publication of that report, and I've just put a link to it in the chat function, we have been circulating that. We've been meeting with stakeholders. We presented to the Oireachtas Transport Committee recently on that, and we felt it was maybe useful to perhaps bring some of those groups of people together, some of the things that we have been talking about for this webinar this morning. So what I would like to say is, if you have any questions that you would like to be putting to our contributors this morning, just pop them into the chat box, and we'll pick up on those as we go on. But first, I'd like to move to our first speaker today, Dave Cliff, who's actually joining us from Geneva in Switzerland. Dave is the CEO of the Global Road Safety Partnership. And you've been there, Dave, since 2017, although I know that previously you had been working in New Zealand. For those who are not familiar with GRSP, it's a hosted programme within the International Federation of the Red Cross and the Red Crescent Societies, and is focused on reducing road trauma in low and middle income countries. I've been looking actually, David, so much of the work, and the work that you're particularly doing with roads policing capacity and kind of building that up in various countries. So I know there's a lot that you'll be sharing with us on what can be done. But prior to joining GRSP, Dave served as the Assistant Commissioner for Road Policing in New Zealand, and was also Assistant Commissioner responsible for all policing functions across New Zealand's South Island. And I think there will be a wealth of experience, and one of the things I think is so helpful to us here in Ireland is when we can learn, when we can see what has happened in other countries, and what perhaps we might be able to pick up on that. So this morning, Dave is going to be talking about the proven power of random breath testing, and in particular lessons from New Zealand and Australia. Dave, if I could hand over to you, I'm really looking forward to hearing your contribution this morning. Thank you.
Right, thanks for that introduction, Sheila. And I'll just share this presentation with you, and then we can make a start. Okay, so firstly, by way of background, random breath testing programs have been operating across Australia and New Zealand since the late 1980s 1990s, they really started to ramp up. So it's very much a standard part of the way in which road policing is delivered in our part of the world. So I'll just begin with a little bit on deterrence to give you an understanding of the background to this. So firstly, we think about deterrence in two ways. We think about general deterrence, which is the threat of legal punishment and its impact on the public at large. So it's not necessarily being affected directly by it, but it's the fear that people have of detection if they break the law. What we know is highly visible enforcement supported by public awareness programs, such as breath testing large numbers of drivers, is the sort of activity that generates high levels of general deterrence. We also know from the psychology of human beings that simple unsafe behaviours, for example, drink driving, where there's one decision made at the beginning of a journey, drive or don't drive, is highly affected by general deterrence. So seeing road policing activity, it being publicised, hearing it being spoken about are examples of general deterrence. The other deterrence mechanism is really catching people. So specific deterrence is the impact that catching individuals and hearing about, obviously, people being caught has on deterrence. But we know that the deterrence mechanisms between different behaviour types, so for example, drink driving versus speeding, are different, whereas speeding requires high levels of catching individuals to deter. Drink driving works in a different way. So I just wanted to make that distinction at the outset. A couple of definitions just to explain. So I'll talk about random breath testing and compulsory breath testing. Really the same thing. And when I talk about that, it's legislation that allows police to stop drivers at any time or place without suspicion, with no legal restrictions at all on when or where tests can be conducted. And I think you have that legislation in place at the moment across Ireland. I'll also talk about booze buses. So these were introduced firstly in the state of Victoria in Australia, and they're really mobile breath testing sites. So it means that when a checkpoint is set up, a driver who, through the preliminary breath test, shows that they're above the limit, they'll then go to this vehicle and be evidentially processed on the roadside. They were really put in place for two reasons. One, it was a very public statement that we take the issue seriously, so they're very visible. You certainly can't miss them. And also it creates high levels of efficiency, so police don't need to take a driver back to a police station. They can process them on the roadside, and it creates efficiency in terms of the volume of evidential tests that are possible. So firstly, just talking about measurement, and this is important, how do we measure whether we're really having an impact? And the most reliable measure of the minimum impact is really this: the number of drivers who are fatally injured and found to have a blood alcohol concentration above this limit of 0.05. The reason that we focus on this measure is because it is generally absolute. So there's a driver who's killed, there's a post-mortem process, a blood sample is taken, and that blood sample is analysed and a result is known. Other measures, for example, where there's no fatally injured drivers, or it relies on police undertaking roadside testing, entering it into traffic crash report. Sometimes they're missed, sometimes drivers aren't breath tested, and so the data is often incomplete. But if we stay with this measuring the number of fatally injured drivers, we tend to have almost all of those being recorded accurately. I want to talk now a little bit about Hommel's principles and who he was. The background is Ross Hommel is a criminologist based in New South Wales in Australia. And when the problem of drink driving was really being identified as a major public health issue across Australia and New Zealand, police went to Ross and said, how do we design a program to deter drink driving? So Ross Hommel, putting on his criminologist hat, said, if you develop a program that follows these principles, so highly visible, rigorously enforced, sustained over time and well publicised, this will have the greatest opportunity to deter drink driving. So the program that was developed in Australasia was very much based on the work of Ross Hommel. And so within police, educating police officers, operational police, leaders in police on Hommel's theory and how it works was very much part of the education and training provided to people like me as a junior police officer, and always took those principles through my career. And we always went back to Hommel's principles when looking at our program and adapting it. There were other key requirements that we identified. One was random and unpredictable times and locations of testing. So drivers couldn't pick where we would be or when we would be there, but know that it was regular and it couldn't be avoided. We discovered the importance of focusing on key risk times. Drink driving, as we know, is not evenly distributed across the week or the time of the day. There are specific high-risk times, which we call high alcohol hours, and I'll talk a little bit about those later, and we need to focus on those key risk times. Then the issue of dosage, and I'll provide some data from Australia and New Zealand showing the volumes of testing that we worked up and decided to focus on to generate maximum levels of testing. In other words, how much testing is required to create the deterrence that we wanted. And then, which something you'll understand intimately in Ireland, is there are differences between urban communities and rural communities, and there's a different approach required to breath testing operations in those different locations. So firstly, in terms of highly visible, it's simple, really. We want as many drivers as possible to be exposed to highly visible random testing. So even if they don't get tested because they're travelling in the opposite direction, we want people to see it because seeing it reinforces the general deterrence message. Look at the police, they're out there. We see signage telling us what's going on, breath testing, prepare to stop. And so this is all reinforcing this message that the police take the issue very, very seriously and are determined to prevent drink driving, so highly visible. Next part of it is rigorously enforced. So the credibility of the program has to be maintained. No one avoids testing. So as the assistant commissioner or my the boss, the commissioner, it wouldn't matter whether we were stopped or the mayor, the prime minister, any public figure, everybody is tested. There is no exceptions if you are stopped. So there's no waving through a taxi or someone we might know or particular vehicle types. Rigorous testing means that everyone is tested. We focus on those high alcohol hours, as I've said. The testing is random and unpredictable, so we don't put in place a checkpoint and leave it there for 3 hours. They're usually shorter duration. They move frequently, so drivers can't predict where they'll be. And we don't keep going back to the same sites so that drivers become accustomed to being stopped anywhere on the network at any time, but focusing on key risk times. And we decided on this target of 1 breath test per licensed driver per year was the target numerically. So it didn't mean everyone was stopped once per year, but on average, we would aim to test people at least once a year. But obviously, if people are tending to travel at night on weekends, they are more likely to be stopped because of the way we target. And with some research that was undertaken in Australia found this in terms of the finding. Many drivers were aware of random breath testing on the roads, but they didn't see random breath testing as random. They could predict where it was going to be, which was a useful piece of information because police were becoming predictable. So in terms of the operational planning, it's got to ensure it is random and unpredictable so drivers can't predict where it will be. We want them to change their behaviour, and they do change their behaviour when they know that they can't predict where that testing will be, but know it is regular. When I talk about high alcohol hours, this is information from New Zealand, and we simply put into each 2-hour period across a week the number of alcohol-related casualty collisions with 5 years of data. And what you'll see there is the highest risk periods, and I imagine it's similar in Ireland, but you would need to look at your own data, from Friday nights at 8 p.m. through to 2 in the morning, and then from Saturday night from 8 p.m. through to 4 in the morning. Those are the absolute key risk times in New Zealand, but other high risk times in the yellow area also are areas of higher risk. So the breath testing operations of police focus on those key risk times, simply because that's when the majority of the trauma is occurring. We know that from this data you will see too that there's no time period across a week that's immune, but it's at a much lower level. And so we've got to use that scarce police resource at times of greatest risk. And I'd really encourage you to use this sort of display to show those key risk times and then focus on breath testing when the risk is greatest across the country of Southern Ireland. For the general public to change their behaviour, the program has got to be sustained over time. So again, where I'm from, we've got dedicated random breath testing groups. They're working across the week, every day, every month, running these operations to maximise the visibility, random and unpredictable testing. But we used to have this belief that we just ran drink drive operations on Easter or Christmas and the problem was solved. We know that doesn't work. It's got to be sustained week in, week out, right across each year. So sustaining the operation over time is very important. In terms of publicity, ongoing publicity to highlight the road policing activity, what it's for, which is to protect people from alcohol-impaired drivers, is really important. So this is part of the general deterrence. You're seeing highly visible operations, you're hearing about them, there's media coverage, there's publicity. And I know there's been some great work done by Velma on publicising the issue, which directly supports enhanced enforcement. Police also add to this by issuing media releases about the number of drivers they tested. The program publicity needs to reach all cultures, age groups, particularly in the communities that are at risk, which where I'm from is often younger males tend to be particularly at risk, and older males who tend to have these entrenched drink driving habits. So we need to identify who our risk groups are and really focus publicity on them. We always pride ourselves on the professionalism of the police operation. So really professionally set up checkpoints, lots of lighting, flashing lights, no ability to evade the testing. Once a driver sees a checkpoint in the distance, they can't turn around and avoid it. There are pursuit vehicles that will stop drivers who attempt to evade checkpoints, and they're very professionally run with an experience. So we talk about the theatre of road policing. So drivers will really remember the event, which is what we want. They'll talk about having been stopped and tested, and you'll hear this often said, that it was like driving through a movie set. Lots of flashing lights, lots of lighting, professionally dressed police, cones, signage, all creating an event in the minds of drivers. I'm going to talk a little bit about this. When we look at what we're trying to achieve as police, we would keep going back to Hommel's bucket, and it's a simple concept, really. We want people in the bucket of deterred drivers. So how do we get people deterred? Well, it's catching people being caught and punished. That's the specific deterrence element. Visible police enforcement, talked about that. That's the general deterrence, very important. They'll hear about people being caught and punished. There'll be publicity on this. They'll hear this from friends. And there'll be publicity about police enforcement. So these processes in combination put people into the pool of deterred drivers. But you'll get leakage. So when you get examples of people talking about they evaded a checkpoint or they took a back road, that creates a problem for us because they'll tell others that they got away with it. If people are not seeing random breath testing sufficiently often and experiencing it, that will add to decreasing deterrence. And as I said, if people avoid punishment, that will also create a problem in terms of a lack of deterrence. So if we're getting an increased detection rate, we will be going back and asking ourselves about how we're meeting each of these criteria, because we want people in this deterred bucket area. So just as an example, while general deterrence is really important, if we really start to explain to the public why this issue is so problematic, the number of people who are being killed and grievously injured by drink drivers, you'll get information coming into police. So as a young sergeant, I remember receiving a letter from an anonymous writer who said, every day at this time, this individual driving this car drinks at this particular local pub. They then get into their car and they drive home. So we made a point of sitting off this bar, stopping that driver when they left and processing them for drink driving. And so specific deterrence is important on top of general deterrence and demonstrating to the public that you're taking the issue seriously. A couple of concepts of what best practice is. This area has been intensely researched by the Monash University Accident Research Centre, MUARC in Victoria, Melbourne. And they came up with some principles. So as an operational police officer, I was routinely being briefed by the university on what the research was telling them and how to improve our operations to maximise deterrence. So here's just some examples. Now, these are specific to Melbourne, but information like this through your university should help, for example, work out what your optimal breath testing volumes would be across Dublin, for example, or your other major cities. So in Melbourne, RBT operations in urban areas that were focused on about 20 hours of activity per 100 square kilometres was the sweet point for maximising deterrence. So we had that as a principle that we applied. RBT in urban areas has residual effects for about 2 weeks. So after we run a big operation, the effect in suppressing drink driving will last for about 2 weeks. And this is a really important one. When we run drink drive operations at high alcohol hour periods, has a big crash reduction effect. When we ran it during daytime, low alcohol hours, we couldn't show any impact. So we have to focus on those key risk times and not waste effort on low alcohol hour testing. In terms of a graphic, this was really intended for police staff to just keep on reminding them about what we're trying to achieve. So road policing is most effective when it's unpredictable, unavoidable, and appears to operate everywhere. It's got to be conducted in an intensive and sustained manner to increase public's perception of risk. It's got to be random so people can't guess where we're going to be. We need highly visible operations. We've talked about that, but also some targeted operations to avoid punishment avoidance for those entrenched drink drivers who do need to be caught, who can't be deterred simply by the visibility. And we need to be supported by mass media and public education to keep on reinforcing those anti-drink drive messages. In terms of impact, here's just a couple of examples, but there are numerous other examples from the Australian states and territories and New Zealand. And what it really shows is this, that when you really start to ramp up random breath testing volume, you see large declines in the number of deaths as a result of drink driving. So scale up and you see the fatalities dropping off. However, equally, when this is Victorian information, there was a decline in testing volumes and visibility. There was an increase in the number of alcohol-related fatalities. So we've got to keep in mind that it's got to be ongoing. But when the intensity was renewed and there were system improvements, we saw this solid drop-off, which has been continued. So this is large-scale testing in the volume of 3 or 4 million tests per year across Victoria, which has a population, I guess, of about 6 million, so probably similar to what you've got there in Ireland. So over time, there's a very consistent inverse relationship. You increase random breath testing intensity, you'll see fatalities drop off. But when testing volumes and visibility decrease, you'll see the deaths rise. There's a very defined formula there. Same for my home jurisdiction in New Zealand. You'll see there the number of deaths involving alcohol-impaired drivers from 1984 down to 2024. Ongoing increases in volume of testing, and you see the numbers of drink driving start to really fall with some spikes when we needed to tinker with and improve the process. And again, high volumes of testing, 3 to 4 million tests a year that are currently detected, with an absolute focus on those high alcohol hours, random and unpredictable testing. I'll just quickly focus on this, and I know time is limited. There is a different approach to rural drink driving. In my country, there's elaborate grapevines, unfortunately, that will often warn drink drivers at pubs about police activity, so the approach is different. So setting up a small checkpoint of a couple of officers, stopping 10 vehicles, going somewhere else, moving frequently so drivers can't predict where it'll be, targeting back roads as well as main roads, marked and unmarked patrol cars, not just large-scale checkpoints with booze buses, because we want to change behaviour so drivers can't take back roads or think they can outweight police. And if you apply this random and unpredictable approach, back roads, main roads, unmarked cars, so drivers come to understand police breath testing can't be evaded, it has a big impact on deterring drink driving in rural areas, which is just so important because of the challenges of dispersed populations and large road networks, which I know you do have in Ireland. So the last couple of things I wanted to touch on one is police leadership. Police leadership really does matter. We've got to create an atmosphere of trust with our officers and the public, explain why we're doing this and explain it to the officers. Educating police on HOML's principles and operational good practice to keep our officers safe is essential. We want them accountable in terms of volumes of testing, but we want to explain why. We've got to maximise tests to keep people safe from drink drivers who kill and seriously injured innocent people. So this is a program in itself. The leadership dimension to good road policing is really important. Lastly, there are other opportunities. So we know there's a very direct link between increasing drink drive when trading hours for the sale of alcohol increase. So when trading hours increase, alcohol-related harm increases. It's associated with increase in assaults, unintentional injuries, and drink drive offences and road trauma. Restricting and narrowing trading hours has exactly the opposite effect. It reduces alcohol-related crime, assaults, and road trauma. So if there's any thinking about extending hours or restricting hours, if you extend hours, you'll increase harm, you'll increase drink drive deaths. If you restrict those hours, you will most definitely reduce your alcohol-related harm. And this information that I'm quoting comes from an assessment of multiple studies from around the world that show the same impacts. So this is just really summarising what I've talked about, which will be available with the presentation, and just highlight some of those key issues. But one of them also to think about is reviewing penalties and system problems. So, for example, I'm aware that in Ireland there's a 3-hour time limit in which police have to undertake a breath test. We don't have that in New Zealand. The approach we have is to test without delay. So if there's a reasonable, there's a test of reasonableness. So, for example, if a driver runs off and tries to evade testing, and we catch them later, they are tested as soon as we practically can, but no one should benefit from simply trying to avoid testing. So there are no time limits. All police have to prove is that they were reasonable about administering the test as soon as they reasonably could. And this, again, is useful because it demonstrates to drivers that there's no benefit in running away or hiding or trying to delay testing, that will still hold them accountable. So I'll close now and pass back to you, Sheila, for the next presentation.
Thank you so much for that, Dave. There's absolute wealth of information on this. I can feel myself that I'm actually just dying to go back and look and go through all the slides again. Just for our audience, I will say that we will have a panel discussion at the end of our contributions. So please feel free to stick any questions that you have into the chat, and we'll get to as many as possible on that. So, Dave, thank you again for that, and we'll come back to some of the many interesting points that you have raised. I'm going to move on now actually to our second speaker, to Velma Burns. Velma is the research manager at the Road Safety Authority. She's been there since 2013, and since then I know that you've been working on implementing the whole programme of data analysis and research to support the RSA in their work in trying to ensure that we have evidence-based interventions really to reduce death and injury on Irish roads. And I know that prior to joining the RSA, Velma, you'd been working for almost 10 years in the field of market research, mainly in the areas of the health sector. So I think, very close overlap there, and very, very useful for us to have those perspectives. So Velma, if you're ready to go, if you wanted to share your slides there, we're delighted to welcome you. Thank you.
Thank you so much, Sheila, for the opportunity to present to you here this morning. And if you just bear with me a moment, I'll get my slides set up. Almost there.
That's perfect.
So hopefully that's all looking good. So good morning, everyone. I'm delighted to be able to present a new piece of research and analysis that we did in the RSA earlier this year. And in fact, we published a selection of slides from this presentation in the context of our recent bank holiday, June bank holiday, a road safety appeal, and that was in collaboration with on Garda Síochána. But I'll go into a little bit more detail on the data and the analysis for you today. So I'm going to focus on the role of alcohol in casualty collisions in Ireland. I'm going to focus on a number of different angles and aspects of this, looking at surviving drivers who were tested for alcohol and had a positive result, but also looking at deceased drivers and also looking at some of our survey data. So by way of background, I'm just going to explain the nuances between some of the various data sets. Give me a moment, my slides are not moving for me. There we go.
That's up now, Velma. Thank you.
Moving now. So apologies, there seems to be a delay on my side. As I said, first of all, I'll give an overview of information available on alcohol test results for surviving drivers who were involved in both fatal and serious injury collisions, as well as toxicology results for deceased drivers. So, as many of you will be aware, the RSA has a statutory remit to report on injury collisions that have occurred on a public road using collision data provided to us by An Garda Síochána. So from this collision data that we receive, drivers may have been tested for alcohol either at the scene of a collision, subsequently at a Garda station, or indeed when they present to hospital. So the road traffic collision data that we received tells us at which, if any of these locations, a test was conducted, and also provides us with the result of this test, be it positive or negative. So from this data, we don't have detailed information on the blood alcohol level. We simply know, was the result positive or was it negative? So this analysis from the road traffic collision data in this report relates to surviving drivers only. And this is the first time we've done this piece of analysis. So it really is quite new, detailed information that we're in a position to present and publish. So toxicology results for deceased drivers, they are collected and reported separately, and we have a mechanism in place for many years to report on this data. And the mechanism is as follows. The Health Research Board collect road traffic collision fatalities data annually on behalf of the RSA from closed coroner files using the National Drug-Related Deaths Index methodology. So this data is collected from closed files once the inquest has been completed. And of course, there is necessarily a time lag for this data to be collected, and I'll explain that in a moment. So these data include detailed definitive toxicology for road user fatalities, and we do have the blood alcohol levels in that data. Finally, I'm also going to include some findings in relation to alcohol from a nationally representative self-report driver attitudes and behaviours survey that we conducted in 2025. So as you can see, I'll be drawing on a number of sources of research and information throughout this presentation. The first area that I'm going to look at is the collision data, and I'm going to look at the proportion of surviving drivers who were involved in fatal and serious injury collisions over a 5-year period. And here on this slide, we're looking at the incidence of testing. So over the period 2021 to 2025, 63% of drivers who were involved in a fatal or serious injury collision were tested for alcohol. And as you can see, based on the year-on-year figures, the picture is quite consistent year-on-year, so that about almost 2/3 of surviving drivers were tested for alcohol. So when we look at where these drivers were tested, in most cases, the drivers were tested at the scene of a collision, that's 55%, 8% were tested in hospital, and 2% were tested at the Garda station. And there is some overlap there in terms of duplication of being tested twice, both at the scene of the collision and at the station. So that does leave us with about 40% of drivers who weren't tested. And we do have good information in the record from An Garda Síochána that tells us why the driver may not have been tested. And I've summarised some of the main reasons here, and the reasons are many and varied, but these are the top 5 reasons that you can see documented here. So in many cases, the driver had already gone to hospital, so the driver couldn't be tested at the scene. In 25% of cases, there was some reference to the 3-hour window that was discussed earlier on, that there is a requirement to conduct the test within 3 hours, but for some reason it wasn't possible to do that test within that 3-hour window, and therefore a test wasn't conducted. In 10% of cases, medical grounds meant that the test couldn't be conducted. So, of course, the driver, in many cases, was themselves seriously injured in the collision, and a test may not have been possible. There were a lower instance of no screening device being available, and in a small proportion of cases, the collision was a hit and run, and therefore the driver was not located to be tested. So you can see quite a complex range of reasons there why a test may not have been conducted. So I'm going to focus now on those who were tested and look at the result of that test. And at an overall level, over the 5-year period, you can see over on the right-hand side, 7% of drivers who survived and were tested had a positive result in that alcohol test. And you can see some slight variation year on year over that 5-year period, but really nothing terribly remarkable in terms of a difference. So pretty much consistent in terms of that instance of less than 10%. And you may think less than 10% doesn't seem to be doesn't seem very high, but in fact, when you look at the actual numbers, that was 384 drivers over a 5-year period who tested positive, which is quite significant when you look at it in those absolute terms. There is some regional variation when we look here at the incidence of positive tests among drivers involved in collisions across the country. We can see the highest positivity rates were in fact in Kerry, Longford, Clare and Tipperary, and we see the lower positivity rates reported in Mayo, Dublin and Sligo. And I think there's likely to be many and varied reasons for this disparity by county, which I can come back to. So here we're looking at the injuries sustained in those collisions where a driver tested positive. So first of all, looking to the pie on the left-hand side of the graph, as I said, there were 384 surviving drivers involved in fatal and serious injury collisions who tested positive for alcohol over those 5 years. Almost half of those drivers themselves were seriously injured. That's 44%. A smaller proportion sustained a minor injury, and almost 4 in 10 walked away uninjured from the collision. However, sadly, 38 people died, and a further 264 road users were seriously injured in that collision with a drunk driver. So that's what we're looking at over on the right-hand side in that pie graph. So I'd like to look now at the road user groups of those people who died and were seriously injured in those collisions with the drunk driver. So that's what we're looking at here. So of the 38 road users who were killed, 7 of those were drivers. So that was the driver of the other vehicles. So in that case, some of these collisions were multi-vehicle collisions. So 7 other drivers died in a collision with a drunk driver. 23 passengers were killed in that collision where a driver had a positive alcohol test. And it's interesting, when we look at those passengers, the vast majority of those were in the same vehicle as the alcohol positive driver. So 20 of those drivers were a passenger in the car with a driver who had consumed alcohol. And I suppose when we know that, that's really important for us in the RSA in terms of our education and awareness activity. And it's really important for us to have this data and to be able to use it to inform our work, to continue those messages to passengers, to empower passengers not to get into a vehicle with a driver who has consumed alcohol. We also see from our analysis that a large number of vulnerable road users were killed in a collision with a drunk driver. So we see 2 motorcyclists, 1 cyclist, 4 pedestrians and 1 e-scooter user over the last 5 years lost their lives in a collision with a drunk driver. Now I'd like to move on to look at those road users who sustained serious injuries in a collision where, again, the driver had a positive alcohol result. Again, looking at the same 5-year period. So starting on the left, we can see that 169 drivers who tested positive, so the drunk drivers themselves, also sustained serious injuries in those collisions. 72 other drivers also sustained serious injuries. We see a large number of passengers again, 143 passengers sustained serious injuries. And again, we see that same pattern that the majority, 73% of those passengers were in the same vehicle as the driver who had a positive alcohol test. We also saw 8 motorcyclists, 3 cyclists, and a large number of pedestrians, 36, and 2 e-scooter users who sustained serious injuries over the last 5 years in a collision with an alcohol positive driver. So moving on to the next section, what I want to look at now is the profile of those alcohol positive drivers and the profile of the collisions where an alcohol positive driver was driving, because it's really important for us to understand what is the gender and the age, what time are these collisions occurring, and picking up on what Dave presented on earlier, what days of the week are these alcohol-related collisions occurring, because that kind of information is critical to inform our evidence-based education and awareness interventions, but also strategic and targeted enforcement on drink driving. So the way I'm going to take you through this piece of analysis is, first of all, I want to present the age profile in these red bars of all surviving drivers involved in fatal and serious injury collisions over the past 5 years. So the general profile of those drivers involved in fatal and serious injury collisions is what you can see here. And you can see in terms of age, it's really quite flat from age 16 right up to age 55. And there's a lower incidence of being involved in a collision than among the older drivers. But then what I want to do is bring in the age profile of those surviving drivers who tested positive for alcohol, those 384 drivers. And what you can see here is that those drivers are much more likely than average to be younger, in particular aged 16 to 35, but also 36 to 45 drivers emerging here. And much less likely to be an older driver. So I suppose this falls into this typical pattern of young driver risk that we tend to see in Ireland, but also internationally. Looking at the same kind of information here now for gender, we see that among all the surviving drivers who were involved in fatal and serious injury collisions, that's almost 9,000 drivers over a 5-year period. We see that almost 7 in 10 of those drivers were male, and we know that males tend to be more likely to be involved in collisions. But here, when we bring in those drivers who tested positive for alcohol, the problem is most certainly male to a greater extent. So again, we're seeing this profile of young male drivers more likely to test positive for alcohol. So here we're looking at the time of day in which all of these collisions occurred among those almost 9,000 drivers who survived. And you can see that really the peak for collisions involving these drivers is from lunchtime up until 8 p.m. But when we bring in those surviving drivers who tested positive for alcohol, profile is entirely different. You can see that the high risk period is very clearly from 8 p.m. to midnight, and then 12 a.m. to 4 a.m. So very much aligned with what Dave showed you with regard to the New Zealand experience. And when we look at the day of week, no surprise here in terms of those drivers who tested positive for alcohol, they were more likely to test positive in a collision at the weekend, Saturday and Sunday, in line with the key hours of socializing. So as I said, this information is really key to inform the targeted strategic enforcement of An Garda Síochána and to ensure that they are testing at the right time where these collisions are more likely to occur, when drivers are more likely to engage in drink driving. So I am now going to move on to share with you some data from coroner's files, and the most recent information that we have available relates to closed coroner files for the period, again a 5-year period, 2016 to 2020. So this data is not as recent as what I just showed you. However, it is still very valid and very important for us to be aware of and to study and examine. And just to say that we will be publishing an more up-to-date analysis from coroner data by the end of this year, where we will be publishing data up to the end of 2022. So there are many reasons why there is this time lag. It takes time for an inquest to be held, for the full investigation by An Garda Síochána and others to be completed, and for the data to be collected and subsequently shared with us in the RSA. And we did have a more extended time lag during the COVID pandemic, which also added to the delay in transferring of this data to us. So we have really excellent coverage in relation to this data that we have from the Health Research Board. So to illustrate that, 316 of the 340 drivers who were killed over a 5-year period had a toxicology result available in the file for analysis. Now, of those, just over a third, so 35% of the 316 drivers who were killed and who had a tox result available had a positive toxicology for alcohol. So a really high level of alcohol. So it's very clear from the data that I showed earlier, and indeed from this, that alcohol is most certainly still a significant problem in Ireland. As I referenced in my introduction, we do have really good information from the coroner's files, from the detailed toxicology report, and we have the blood alcohol level. And it is very clear from this analysis that the drivers who were killed and who had a positive tox, they mostly had very high levels of alcohol in the blood. So they were very severely impaired at the time of the collision. So almost half, 46%, had a blood alcohol level in excess of 200 milligrams per 100 mils of blood. So that's over 4 times the blood alcohol level. So very high levels of alcohol at the time. In terms of the profile of those drivers who were killed and who had a positive tox for alcohol, we see the vast majority were male. 3/4 of them were aged under the age of 45. We see that same pattern again of these collisions more likely to occur at the weekend, and also more likely to occur late at night into the early morning. We also see that 3/4 of these fatal collisions occurred on rural roads with a speed limit of 80 kilometres and above. We also see from this analysis, and I'm not going to go into detail on this, that the drivers who had a positive tox for alcohol per this coronial data are also more likely to engage in other risk risky behaviours, are also more likely to have exceeded safe speeds, also more likely to not have worn a seatbelt. So we see this pattern of multi-risk taking in this data, which we also see in other research. I'm now going to move on to look at some of our survey data. So we conduct an annual survey of driver attitudes and behaviour every year. It's a nationally representative online survey of almost 1,300 motorists aged 17 plus, and we conducted the most recent survey in October of 2025, but we have a really good historical bank of data from this survey. We cover all of the dangerous behaviours, but we do have a specific section looking at alcohol. So I'd like to just present some of the findings of this, again, to add to the evidence to inform the discussion here today. So as part of this survey, we ask drivers, have they driven after consuming any alcohol in the past 12 months? And that's what you can see in this line graph from 2015 to 2025. And typically we see on average 1 in 10 motorists say, yes, they have driven after consuming alcohol. But what's very apparent is the direction that line is moving in. There is certainly a growth in self-report engagement in drink driving evident from this study. So in 2015, 8% of drivers admitted to drink driving. That's up at 12% in 2025, which is a statistically significant difference over that time period. Of that 12%, male drivers were more likely to admit to drink driving. Also, those who were previously involved in the collision were more likely to admit to drink driving. And those who engage in other unsafe behaviours, such as speeding, were more likely to say in this study that they engaged in drink driving, again, pointing to that pattern of multi-risk taking. We also cover in our survey this idea of social acceptability of drink driving. So just to explain what I mean by that, in 2025, 80% of motorists told us that it's not socially acceptable to drink and drive. But if you look at the COVID years in that line graph, so 2020, 21 and 23, you can see that a lower proportion of drivers said it was socially unacceptable. So we certainly did see a regression in road safety behaviours during the COVID pandemic. So things are starting to recover a little bit based on this data here and this time trend analysis for social acceptability. But it's still concerning that there is a cohort out there who believe that it is socially acceptable to drink and drive. In this study, we also ask a number of other questions, and just to highlight two that you can see over here on the right-hand side. And this first one really is quite concerning. 1 in 4 motorists agree that driving a short distance after having a drink is acceptable. And really, it is an interesting one from a psychological perspective. And we do see it in other qualitative research that we conduct, this idea that motorists make excuses for their behaviour, that they may not go on a long journey, but they think driving a short distance, maybe from the pub to their home, it might be a quick 5-minute journey or whatever, and they think that that's okay. And of course it isn't okay, because any amount of alcohol impairs your judgment, impairs your ability to drive safely, and can have devastating impact, as we can see from the data in this presentation. 1 in 4 motorists also agreed that they may have been over the limit when driving the morning after a night out. So again, really good to have these statistics available to us, and that helps inform some of the work that we do, some of the education around the morning after. We know that that is certainly still a problem. So picking up on some of the information that Dave referred to in relation to the importance of enforcement and testing, again, on our surveys, we like to cover this topic as well to inform the available evidence in Ireland. So in the past 12 months, we asked our motorists, how many times have you been checked by the police for alcohol while driving a car, i.e. being subjected to a breathalyzer test. So 83% of motorists said they've never been tested in the last 12 months, 13% said they've been tested once, and 4% tested at least twice. So that's at an overall level, 17% tested for alcohol at least once in the past 12 months. And it was really interesting, Dave, to hear from you in relation to the best practice recommendation around testing every licensed driver at least once a year. And then just over on the right-hand side, just to bring in the stat, again, pointing to the importance of deterrence, 11% of motorists think it's likely that they will be checked by police for alcohol on a typical journey. So clearly the deterrent effect is not that widespread among motorists that they think they will be likely to be checked. And it's really important that that deterrent effect is there to deter engagement in drink driving. So just a couple of conclusions in relation to the data that I have presented, and I'll just finish up then really quickly by talking to some of the interventions that we're working on to deter drink driving. So clearly from this analysis, drink driving is a significant problem on our roads. So in addition to a large number of drivers who drink drivers being seriously injured, 38 other people died and a further 264 road users were seriously injured in a collision where a driver had a positive alcohol test. It's clear from our analysis that prevention initiatives should focus on younger male drivers specifically, and also driving late at night and into the early morning and at weekends. Also clear from this analysis that empowering passengers to not get into a vehicle with a drunk driver is critical. And I suppose from a research perspective, we're always looking for better data, more complete data, and I think it would be really helpful for a further examination of barriers to alcohol testing to be considered. So here I'm referring to alcohol testing at the scene of a collision, so that we would have more complete information in relation to the prevalence of alcohol among surviving drivers involved in collisions. So it's clear we have a significant problem. What can be done about it, and what initiatives are we in the RSA leading out on? Well, alcohol forms part of all of our road safety education programs, and up on the top left-hand corner, that's just a screenshot of our new TY program, Road Safety Matters, in which all of the dangerous behaviours are covered off. And it's really important that we educate young drivers pre-driving before they have an opportunity to engage in these behaviours. So education is really important. Alcohol is covered extensively across all of our education programmes. Over on the right-hand side here, we have our flying box breathalyzers, and these are mobile breathalyzers. Some of you may be familiar with them. We have a collaboration with Flying Box, and they are in situ at festivals right around the country. And here it's really about empowering young people to make safe decisions about getting behind the wheel, so that they can test themselves at festivals before they leave, before they get behind the wheel, to know are they positive or are they negative? And indeed, that covers off the morning after risk as well. In the bottom left-hand corner, just a screen grab there of our Blood on Your Hands TV-led campaign, which we launched last year, and which is very impactful and talks to the dangers of drink driving, but also talks to bystanders really, and friends and family, and the role that they can play in ensuring that drivers can get behind the wheel only when they are safe to do so, not getting behind the wheel after consuming alcohol. In terms of policy work, alcohol ignition interlocks are really, it's a very it's an evidence-based program, and the international research is very compelling that alcohol interlock programs can reduce reoffending by up to 75% when fitted in a vehicle. So we in the RSA have done some work in relation to this in the context of the Government Road Safety Strategy Action 23, and a report has been published summarising some of the evidence, and it was presented at the 2024 ETSC Safe and Sober seminar. And in the phase 2 action plan, the work is to be continued. The Department of Transport are now reviewing the report and looking at the potential to consider the possible introduction of mandatory alcohol interlocks alongside rehabilitation courses as a sanction for drink driving in certain cases. So that's it from me. Thank you very much for your attention, and I look forward to the panel discussion.
Oh, Velma, thank you so much for that. Very, very much appreciate. There's an absolute wealth of data, that has been shared there. I'm very much looking forward to going through it in depth and indeed hearing any questions about it. So we're going to move on to our panel discussion, and I'm going to actually bring in two of our other panelists. Leo Liegio, I'm just going to check firstly, Leo, that you're able to join us at the moment. So Leo, you might like to turn your camera on. There you are. Hello, how are you doing? Lovely to see you. Just for the benefit of those who are around us, we were having a little bit of texting and emailing in the background just to make sure that we were able to get you there. So
you can hear me okay, yeah?
We can indeed. I'm very conscious that over the last, two speakers, we've been talking about data, and we've been talking about, trends and different things like that. But behind all of that, there's the individual stories, there's the individual families, and there's those who are really up close and dealing with that pain and that trauma. So the two people who are joining us this morning are people who really do see this up close. So Leo Liegio is he's Vice President of the Irish Road Victims Association, and Dr. Owen Fogarty is a consultant in emergency medicine and retrieval medicine in Cork. Leo, I'm going to just come to you first of all, and even just sort of like your own response to some of the data and what you're seeing there, and what you within IRBA, what your response, I suppose, is to these issues that are being raised around road safety.
Well, first of all, Sheila, I want to thank you and Alcohol Action Ireland for inviting the Irish Road Victims Association to be part of this. I don't have any slides. I don't have any statistics. I have, like you said, just a photograph of my own daughter. We've already heard the evidence, the research, and the international experience, but I'd like to talk about the people behind those statistics. 20 years ago, my 16-year-old daughter, Marcy, was fatally injured in a road collision. She survived for a week in hospital before she died. In that moment, our lives changed forever. That experience is what brought me to the Irish Road Victims Association. Today, I have the privilege of supporting families across Ireland who are trying to come to terms with losing someone they loved, or caring for someone whose life has been completely changed forever by a road collision. Also through IRVA, I've had the privilege of speaking to thousands of young people throughout the country with the AXA Road Safe Roadshow and local county councils and Rotary clubs. And one thing I've learned is that road trauma doesn't end when the emergency services leave or when the court finishes. Families live those consequences forever. At IRVA, we support families whose lives have been devastated by road crashes. And every day we see the unimaginable pain that follows a crash, follows that knock on the door, a phone call from the Gardaí, or a visit to the hospital. Behind every statistic is a person whose future has been taken away, and a family whose lives have been changed forever. Drink driving remains one of the most preventable causes of death and serious injury on our roads. While public attitudes have changed enormously over the past few decades, the reality is that people are still dying and suffering life-changing injuries because of someone made a wrong choice. He made a conscious decision to drive after consuming alcohol. As a victim support organisation, our focus is always on prevention. We want to stop families ever needing our services. Education has a vital role to play, but that must be supported by consistent enforcement, visible roads policing, and public awareness campaigns that remind people of the devastating consequences of drink driving. Technology has also an important part to play. Measures such as alcohol interlocks for high-risk offenders, together with continued investments in roads policing and evidence-based rural road safety initiatives, can help prevent tragedies before they happen. When we talk about drink driving, it's easy to focus on the statistics, percentages and trends, but every number represents a person. It represents birthdays that will never be celebrated, empty chairs around family tables, children growing up without a parent, and parents mourning the loss of a son or daughter. And families whose lives will never be the same again. However, we believe no family should have to endure that pain. It can be prevented, and every life lost on our roads is one too many. And every death or serious injury caused by drink driving is a stark reminder that we cannot become complacent. Road deaths are not inevitable. They are preventable. Preventing them requires all of us, government, policymakers, enforcement agencies, road safety organisations, communities, and every road user to play their part. If today's discussion encourages even one person to leave their car behind after drinking, or helps shape one policy that prevents another family from experiencing the devastating knock on that door that so many of our members have faced, then it would have been worthwhile. People sometimes ask me what success means for ERVA. The answer is very simple. Success is having fewer families to support because fewer lives have been shattered. We want to be put out of business. And again, road deaths are not inevitable, they are preventable. Every life saved is another family spared, a lifetime of grief. And that's what I'd like to say.
Leo, thank you so much. I can only say that it's absolutely devastating to listen, and I therefore cannot even begin to imagine what it is to experience. Thank you indeed, and I really appreciate you taking the time and to share that beautiful picture of your daughter, and to help inform the work that goes. Owen, I know that you're somebody who very unfortunately also meets in people in horrendous circumstances. I'm just maybe going to move to you. Actually, Owen, I'm just going to as well just ask if you could unmute yourself there, so that you're able to speak. Sorry, and just Owen Fogarty there, if you're able to unmute. No, what do you say?
Thanks very much for being part of today. So, first of all, so my background is as an emergency medicine doctor, and I also have a specialist in ambulance work. So, unfortunately, my day-to-day job for the last over 20 years is meeting the families like Leo's daughter, and it's usually a completely unexpected event for them. And unfortunately, last year it happened 190 times. That's unacceptable. Dave's talk was brilliant, and I recall myself working in Australia where it was a lot more streamlined, the ability to take samples from an intoxicated or otherwise driver. So, for instance, Velma spoke that the reasons for patients not getting tested, one of the biggest reasons was patients gone to hospital 28% of the times. That's complete nonsense. I mean, there's nothing stopping me, or there shouldn't be anything stopping me, walking up to the driver and taking the sample there and then and pushing it into a safe like I did in Australia. The next big reason for people avoiding getting a test done was that there was an insufficient time. We have a 3-hour time limit in Ireland. This doesn't exist in other jurisdictions like in our neighbour in the UK. But that means that if you crash your vehicle and you're intoxicated, legal teams will use the excuse of it took maybe 3 hours, maybe, to get the sample. That just needs to go away. There's no logical reason having a 3-hour limit, in my opinion. There is an argument that maybe members of An Garda Síochána might think, oh, I've got 3 hours to take the sample. I can delay a little bit doing other stuff. That doesn't make any sense. That's not real life as far as I'm concerned. The 3-hour limit just needs to go. The last point I'd make, though, is Dennis Cusack recently put out a report today about drink driving samples and whatnot. And one driver was arrested 6 times in the last year for suspected drink driving. This is completely illogical in a normal society, that someone is allowed to go out, and usually they are intoxicated when they get arrested and the sample's taken. And that means they're given their car back each time. So one of the worst things Gardaí have to do is hand the keys back to the person of the vehicle that they may have killed somebody in or injured somebody in the very next day. And it's just wrong. And so the key messages that I have been promoting are to remove the 3-hour limit, allow doctors in hospitals to take the samples by removing the need for Garda caution, and finally we need to take it serious that there is a strong prevention in stopping that individual who's failed their roadside breath test from going back into the same vehicle the very next day. So vehicles need to be taken off people who are failing samples, and they're just not responsible people on our roads out there.
Thanks very much, Owen, for those comments. Those are very practical things that you're putting forward, and to say you're speaking as somebody who's on that front line of really seeing things. So it's really good to get that perspective. And encourage our audience to put any questions that they have into the chat box. But there was a few things, that were just occurring to me as well. And maybe I'll just also ask Dave if you're able to switch your camera on, and we can have all of us on the panel here able to see. Velma, there's an enormous amount of data in what you have. Just one thing that I wanted just to perhaps pick out at the moment it was just that geographical spread that you had. I'm just conscious that we have a number of people from all around the country, actually, in different county councils and road safety partnerships there. So I wonder perhaps just if you could just speak a little bit more to that kind of variation that you were seeing.
Sure. And as you rightly say, there was quite considerable regional variation by county in terms of the percentage of drivers testing positive. And I think there are probably a few reasons behind that. So initially, when I looked at the data and when I saw that Dublin had the lowest incidence at 4% of drivers with an alcohol positive test for alcohol, I thought, well, there could logically be some reasons for that, in that Dublin, of course, is better equipped in terms of good public transport mechanisms. You can get a taxi at any hour of the day. You have buses, Darts, Lewis's, etc. But certainly taxis for those high risk hours are readily available. So that could be part of the reason why Dublin is so low. But also when I looked at the instance of testing for Dublin in fact has the lowest incidence of testing. So 55% of drivers involved in collisions were tested in Dublin, compared to up on 70% in some counties. So I suppose there is that context behind the numbers, that the incidence of testing is also likely to influence the positivity results. And similarly for Mayo, I was surprised that the incidence of alcohol positive drivers is so low in Mayo, because it is a very rural, large geographic county with poor public transport system. So I thought that would be higher. But interestingly, also there's a low instance of testing happening in Mayo, and there may well be some very valid reasons for that. But it is a complex picture, but certainly a lot of variation around the country. There's no doubt about that.
Thank you indeed. And actually, just if I could move back to Dave there, just on that very question of testing and level of testing. So I know that here in Ireland, roughly speaking, we're carrying out about 180,000 breath tests annually through the checkpoints at the side of the road. And 180,000 sounds like a lot, but on the other hand, we have about 3.5 million drivers who are licensed to drive. And I was very struck by the numbers, the amount of testing that's actually happening in the data that you were presenting. There was a number of things, but when you were seeing millions, literally, being there, just maybe if you want to just pick up a little bit on that.
Yeah, over the years, there's been a real focus on working out the right volumes, and one test per licensed driver per year was the number that the Monash University Accident Research Centre came up with. So volume really does matter. So if people experience the testing and know, again, it's regular, they're more likely to be deterred. So there's no doubt that volume definitely has a big impact. If people believe it's likely they're going to be tested, they're less likely to undertake the risk of drink driving. So I'd certainly be an advocate for significantly increasing volume. Now, as a former police officer, I know you can't do that overnight. It does require resourcing. But when we went to Treasury looking for more resource in terms of equipment, police time to do this, there's a very compelling benefit cost ratio. If you look at the research, if you put $1 into drink drive enforcement, the payback is very significant in terms of the reduction in cost, and that's particularly in the health and rehabilitation areas. So, a good government who looks at investment will be investing in police because it's highly cost beneficial to put more resource into breath testing operations. Within the police itself, having dedicated teams. So our approach, for example, was we would take recruits when they'd left the police college, they'd had their initial training, and the usual approach is they would be put into dedicated breath testing groups for the first several months of their careers to do nothing but breath testing. So really embed the psyche, the knowledge, the experience, so they could do it really well and efficiently and effectively. So that's certainly my experience.
Absolutely. And I just see a question coming in there. Can Dave, to you specifically, Dave, can you talk about how having the booze bus at RBT locations helps ensure positive test results in convictions? And I know one of the reasons that Owen might be just saying that is that one of the issues that we have here in Ireland is that even when a positive breath test has been achieved and somebody is taken to court, there's quite a high likelihood that the conviction, that they will not be convicted in court. About 37% of drink driving cases don't result in a conviction. So just interested to hear, indeed, your thoughts around that.
Yeah, so there's two parts to it. The booze bus is really about two things. One is it's a very visible public statement that we take this risk really seriously. We've invested in vehicles purely to undertake evidential testing. So the booze buses are equipped with evidential breath testing instruments. The driver is taken from the roadside directly into the bus and they're processed immediately. Very, very little delay. So it's efficient, it's highly visible. And in terms of the prosecution success rate, we also had that problem, and the way in which it was addressed was attached to the legislation was a thing called a breath test notice, and it was a codified process that police had to follow to administer the breath test so that it was evidentially correct. And so police were simply trained in follow the checklist, which they have in front of them when they're doing the evidential test. And we also had reasonable compliance provisions within the Land Transport Act. So a small deviation from process wouldn't affect the conviction outcome, as long as the compliance is reasonable on behalf of police. So that really made major changes. It's far more likely people will be convicted. Police are well trained. They follow the breath test notice, the codified process. And as I said, there's no testing time prescribed in law. It's simply without delay. But if the delay is reasonable in the circumstances, that's fine, and the testing process can continue.
Absolutely. Thank you, and indeed. And Leo, I see you're putting in a comment there. In 2010, there were 500,000 breath tests carried out. In 2025, that it was down to 190,000, while the population grew by 1 million. That's a 62% drop. Yeah, you know, you end there saying it doesn't make sense. It literally doesn't make sense. Dave, can I just actually ask then, so the material that is gathered in the booze bus, the evidence that's gathered there, you're not actually then required, the police are not then taking the suspect back to a police station or anything else. It's whatever is gathered there at the time that becomes the evidence. Am I correct on that?
It is, and they're issued a summons on the spot to appear in court within 7 days. They can be arrested, but there's a preference not to, but they're also forbidden to drive, so they can't drive off, obviously. And there's also quite tight penalty regime, which does have vehicle confiscation, immediate license suspension, and various other aspects. So when I talked about reviewing penalties and process, addressing this issue of having someone drive off or drive soon after can be addressed through legislation which tightens up on immediate license suspension for particularly high readings or repeat offending, vehicle impoundment in certain circumstances. So a robust regime covers off these sorts of risks that were talked about by some of the earlier presenters, which are absolutely real. Some are habitual offenders and drink drivers, and law needs to take account of dealing with them.
Thank you indeed. I think, I mean, I know Owen Fogarty, like, you know, Owen, you'd very specific in that frustration of seeing, you know, repeat drink drivers, both obviously drink driving and that, but also ending back up in the hospitals. Like you're seeing it up close. So I think, you know, one of the things that can happen, you know, here in Ireland is that, you know, we can be maybe a little bit inward looking, that we're looking, you know, well, this is the way it's always been done. Is that I think when we look outwards and you look at a population, you know, which is, you know, comparable size to your own, and seeing different approaches. I know, of course, you've worked in other jurisdictions and you know, have seen that yourself. Is there any other aspect, and I'm just sort of wondering here, maybe again throwing this open to the whole panel, are there any other examples internationally that people are able to point to say, actually this is definitely something that we could look at beyond what perhaps has been raised at the moment?
Sheila, I might just mention the alcohol interlock devices,
Yes,
maybe just to
yes.
explain for people what they are, because not everyone may be familiar with them. So really what it is, it's a breathalyzer device attached to the vehicle. So you have to have a clear reading before the vehicle will start. And in a number of best practice countries, these programs are in place and are in place very successfully. And what they do is they separate the drinking from the driving. And in particular, a lot of the research would point to drink driving happening among those who have alcohol use disorders, who have an illness, if you like, and are problem drinkers. So how many of these best schemes work in other jurisdictions is that they are supported by an education program called a rehabilitation program. And the research shows that these programs work best in conjunction with the rehabilitation program, whereby the driver is educated regarding the risks and the impact of alcohol when driving, and there is this supported program throughout a period of maybe up to 2 years. So this is a major policy intervention in place in other countries. The evidence is very strong that they work. As I referenced briefly, they have been known to reduce reoffending by up to 75%, and the international research is very conclusive in relation to that. So that is something that has the potential to make a big difference in the future. So that's definitely a big policy intervention of note.
Absolutely, I'm very, very pleased indeed, and hopefully that would move forward. I do see a question, Velma, it is put to you, but it possibly is not something that you're actually able to answer. But you know, the question is essentially based on the statistics. You know, what, if any, commitment has been made by An Garda Síochána to increase the number of breath testing checkpoints, and what level of increase has been given. I think that's possibly a question that we would actually have to put to the Gardaí themselves, on that. But it's certainly, I know from an AAI perspective, this is exactly what we are trying to advocate for, and seeking meetings, and we have met with senior Gardaí, and we have met with senior politicians in this area. This does come down to resourcing. We're coming up to a budget. There's a lot of discussions about things that maybe could or couldn't be done. I'm just throwing one in here. We want to see more resources put in this area. Where do those resources come from? Alcohol excise duties have not increased since 2014. We have been advocating for a variety of reasons that there should be at least a 15% increase in those duties. Alcohol costs Ireland at least 14 billion annually. A substantial amount of that is health costs and loss of life and the issues that kind of arise from that. 14 billion is what it costs Ireland at least. If we look at excise duties, what comes in is 1.2 billion. So there's an enormous gap between if you like, the benefit, in the sense of what comes in to the Treasury versus what is actually going out. So I think that's one thing that I'd be saying myself. I see another comment, Leo. You're saying there, wouldn't it be a great idea if all new cars should be fitted with these interlocks as a safety measure? Vilma, am I right in saying that new cars at the moment have to be fitted with the technology that would allow these cars to do that? Is there any discussion just a little bit more about the likelihood, in the same way as we have seatbelts, in cars, that it would just be a matter of form that the actual alcolock would already be there?
I'm not sure. I know as part of the general safety regulations, so vehicle standards for cars per the EU, they must all have the functionality to allow an alcohol interlock device to be fitted. I suppose one area where we have done some work in Ireland is in relation to vehicles that drive for work, and some vehicle fleets do already have these devices fitted. And just to give one example I'm familiar with, our RSA fleet cars do have alcohol interlock devices fitted. So you must blow in before you start the vehicle. And we have been doing some promotional work as part of our Driving for Work programme to encourage fleet operators to include this technology as a starting point. But really, where we're looking at what we're looking at in terms of the policy work is trying to get these programs in place for those drink drive offenders who are at a higher risk of reoffending.
Oh, absolutely. I'm actually just sort of wondering too, is there a benefit? There's obviously a benefit to the companies who are fitting this, in the sense that hopefully none of their drivers will ever be involved in this type of collision. But I'm also wondering, is there a benefit in terms of reduced insurance costs, if people are actually doing that? And again, I don't know if you would know anything about that. It's just something that would come to mind on this. I'm aware that we're just actually gone beyond 11:30 at this point, and probably ask, is there anybody else on the panel who has something that they wanted to contribute that we felt that we didn't get a chance to cover at any stage? Or are I think we're looking okay there. I suppose then for me, really what I want to say is a huge thank you to all our participants here today. The wealth of knowledge that you have, both on the very personal level, which is the thing that really strongly motivates me and so many others to want to keep working in this area, but then the depth of the research knowledge and the being able to share what happens in other jurisdictions. It's great to know that there are solutions, there are things that can be done. Sometimes, in policy work, you can be kind of going, I don't really know what the answers are, but I actually think that we have a roadmap, and I really just do want to thank people for being able to point to, here are things that can be done. And I would just so hope that next year we would see an improvement certainly not anything worse than what we're already seeing, and start to see, policies coming in place so that there will be fewer families getting that knock on the door. So again, thank you to all. We will be making the recording available, and we look forward to seeing you at all our events. Bye now.